super grateful to be here. My name's Tom Bannard. I use he, him pronouns. It's very cool, just briefly, to just reflect on kind of this conference this is our 7th conference, and we did this because we, as universities, need to do a better job of getting research into the hands of people, hopefully in a way that they can use it, and being a part of our community and lend our resources to our community to make meaningful changes in the way we treat substance use. And frankly, when I got to VCU, it kind of pissed me off that I would go to like a lecture at lunch and hear from a world-class, psychologist, psychiatrist, whatever, in a room of 11 people, and that we were not doing a very good job of making good science accessible to folks in a way that was actionable. So it's been a really cool journey, and I'll tell you a little bit more about myself, and then Mara will introduce themselves. Oh gosh, there she is. So this is my daughter, this is Inez, and so I am a person in recovery, and for me that means that I was in a really, really dark place in 2006. I was contemplating a one-car accident. My addiction had completely taken over my life. And I was really fortunate that I was connected, that our family knew somebody who was in recovery, and that person connected me to someone who connected me to long-term treatment. And then I was very fortunate to get follow-up care, and I was very fortunate to participate in one of the few collegiate recovery programs in the country when I did go back to school. And so I quickly realized as I became a professional in the field that the services that I got that allowed me to be successful is something that are services that the vast, vast majority of Americans, even to this day, 17 years later, don't have access to in terms of long-term quality care. And without that, I would have missed these moments, that the joy that has continued to grow in my life, 17 years later, and yeah, I just would have missed these moments. So you've heard a fair amount about RAMs in recovery, but one of the things that just brings me joy is giving folks an opportunity to get meaning and purpose in their lives and to develop further on in their careers. And RAMs in recovery has really given me that. It also, has allowed us to expand our continuum of care and focus on long-term recovery support. So I'll turn it over to Mare.
All right, so I do not have a cute baby picture to show you. I'm very sorry. I do have over 11 years in clinical recovery treatment, mostly in community mental health. And when I was there, I realized that the social is really key to how people move through recovery, and that trauma breaks the bonds of what people are, how people can move through those social worlds. And so my big focus when I went back to school was to look at recovery networks. So this is actually where my research interest is social supports in recovery, looking at trauma. And then I went and did another round of education and training, actually with our first speaker for today, Jess, hey, looking at the impact of family history and family support. And all of this was in the context of Recovery Capital, where we're looking at how people are progressing through their journey. The other thing that I wanted to point out is, as you all can probably see, I am disabled, and I am also queer, trans, and non-binary. And so I bring that lens as well to my work, focusing on marginalized populations, as well as social justice and advocacy work. So that's part of what I will be talking about later on in the slides. We'd like to acknowledge, of course, our funders, as you can see on the your left, as well as the willingness of our partner, Spit for Science, to provide us with data. Most importantly, though, we couldn't do this without the CRP directors, as well as the students in recovery who have participated in the project. And we'd also like to mention that we have had multiple PIs, so that's principal investigator, for the study. I am the most recent one. And this is our study team, some of whom are actually in the audience.
So what we're going to be talking about is what we call the core study, or the National Collegiate Recovery Study. And the way that we put this study together was to gather a team that had already been meeting around doing other work around recovery identity, around kind of understanding recovery, called the Recovery Research Collaborative out of Kennesaw State. And they had gathered a number of folks that are program coordinators at Collegiate Recovery Programs, researchers that study recovery, and most of our team are folks that identify as in recovery, and so that was really important in the study design. We really wanted this to come from the perspective of folks that work in programs, and to develop questions that mattered in terms of informing programming, both for collegiate recovery programs, but probably more broadly for, how do we build recovery community organizations, right? And I often think about Ramsden Recovery as a recovery community organization that just happens to be on a college campus. And so I think there's a lot of things, or I hope there's a lot of things in here that are more broadly applicable. Now, we were going to have a slide here that was like, here are all the problems around substance use on college campuses. And I don't really have to explain a lot to folks about most college campuses are abstinence or recovery hostile environments, right? They literally just put in a vape shop across the street from the recovery clubhouse, right? We're 1.5 blocks away from the ABC store, right? So this is an abstinence hostile environment here that we as a society choose to say, even though we know that folks on college campuses have way worse substance use issues than other folks, we still have lots and lots and allow for lots and lots of accessibility to legal drugs of addiction. Okay, so we kind of start these slides with some quotes from students, and I love this quote: "Collegiate recovery programs were not available at my undergraduate university, but have been an incredible asset during graduate school. A safe, healing place. I've met wonderful friends. It's a lifeline for me." And so one of the things that I love about this quote is it gets at that we do have college students in recovery across our country who are not supported, right? And it doesn't necessarily mean that they're going to have a terrible life or they're going to return to use, though I think we have some evidence that suggests that they're more likely to return to use. But there's something really lacking in their experience when these supports are not in place. So again, about the study, we wanted the study to reflect the lived experience of recovery, meaning that the survey is almost entirely put together by folks who are in recovery. We want it to be longitudinal because the state of our research around addiction treatment and recovery is not good enough. It's mostly 3 months or 6 months or 9 months. And I care about what happens with my students in 5 years, in 10 years, and we should be thinking about recovery research in terms of decades and not in terms of months. And we also wanted it to be compatible with existing substance use research. So we'll talk more about this later, but we worked with folks that study addiction to design the survey such that the questions about problem severity aligned with other studies that have been done around college students, right? So we could create some comparison samples between kind of quote unquote normal college students and college students in collegiate recovery programs. And then finally, it's always been really important for us to provide actionable data to programs. And so as a part of the study, we give any of the participant schools, we give their data back to them. If they have at least 10 participants, we'll give their data back to them, and that allows them to improve their programming.
So, who are these students who are in collegiate recovery programs, and what are some of the challenges that they've faced? As you can see in the quote, a lot of them find that this is essential to their success, but I also want to highlight the older student piece, and that's actually very indicative, or that's very typical. There we go. It's late in the day. So as you can see, our average age here for the study population is about 28, 29 years old, much older than your typical undergraduate program participant. And we also, as we found, this is actually representative of what we're seeing in our university population as a whole. 40% of our study participants identify as LGBTQ in some form, and that, again, is very representative. You can see that with our distribution of gender here. We have about 56% identifying as female, about 10.5% identifying as non-binary, and I want to point out that trans folks are included in the male and female. One area that is something we are trying to work on, but is also a reflection of the state as a whole in terms of who are participating in collegiate recovery programs. We are very heavily white in our survey, and this is very reflective of what we do see in the programs themselves. And this is an area that we are going to be talking about more tomorrow. So one of the things that we also track here is how long folks have been in recovery. About 92% report that they are abstinent from their primary drug of choice, with about 62.5, 63% having at least a year, and about 21% having at least 5 years in recovery, or 5 years of abstinence, which is indicative of really long-term recovery at that point. About 80% associate a date with the start of their recovery, and of those, the participants reported an average of about 3 to 4 years of recovery. We do want to point out that we do have a lot of folks in our study who are not abstinent but consider themselves in recovery. All right, this is what our students are using. These numbers are not going to add up to 100 because most of our students are actually using more than one substance when they were using. 91% have used 2 or more substances at least once. 66%, 2/3, have used 2 or more substances more than 5 times, which is an indicator of basically more chronic use or more heavy use. And about 3/4 of our study have smoked more than 100 cigarettes, which is an indicator of becoming tolerant on cigarettes. Our most common, though, are alcohol and cannabis. Okay, so challenges they've faced. We have students who are facing a lot. A lot of our folks have experienced an academic disruption because of either mental health or substance use. 35% report overdosing at least once. 46% report having some criminal justice involvement. Tom will talk a little bit more about that group later. And about 83% report a family history of substance use disorder. So thinking back to our first talk this morning, we know that that history is extremely important. However, the flip side is that about 45% report a family history of recovery. And emerging research is showing that that's very important for folks to have that recovery capital, to have that depth of knowledge in their family that recovery is possible. Mental health challenges are another big one for us. About 95 to 96% report having been diagnosed with some sort of mental health or behavioral health disorder. 65% report being diagnosed with substance use disorder. Now this says that there's a whole chunk of folks out there who never actually went through formal treatment and got a diagnosis. That's what that's saying. About 66% have depression and or anxiety. 57% have engaged in some form of self-harm, and 37% have at least one suicide attempt. So risk factors there. In terms of socioeconomic status, our students are carrying a lot of debt, which is pretty normal for students these days. But about 55% report that they do have some debt. That average, or actually the median debt, is about $24,000 that they're carrying. 40% are first-generation college students. So we are seeing a lot of folks who are coming in without that depth of resources that somebody who might have a family history of college experience. And about 33%, a third, say that they often run out of money for food during the month.
Yeah, and I have to give credit to Keith Murphy for these questions that we added. So one of the nice things about our study is that we try to kind of regularly feedback to our program directors, and we say, what questions are we missing? What are we not asking, right? And a lot of these questions came out of some of those conversations.
Yeah. So again, you'll hear a little bit more about these groups of students and participants tomorrow in the talks. But our minoritized students do actually experience quite a bit more issues than the white and non-queer do. So of the folks who report, this is fairly new data as well. So we only collected this in the most recent round of surveys, so that's why the numbers are so low. Of those who reported a non-white race or ethnicity, roughly 75% report experiencing discrimination. And as you can see, there are a lot of different spaces that we as college educators actually control where they're experiencing this. So at school, for example, thankfully none experienced it at their CRP or reported experiencing it at their CRP, but recovery meetings, getting counseling, getting medical care, all of those spaces are places where people are experiencing discrimination. And the same goes for our queer students. About 50% of them report experiencing some form of discrimination. Quite a few report experiencing it in recovery meetings, their CRP, as well as getting counseling and getting medical care and at school. So again, these are issues here. We don't know exactly what form the discrimination takes, but these are issues that we need to think about.
And I think in the broader context here, not just in terms of collegiate recovery folks, is thinking about professionals, peer recovery specialists, referring folks to meetings, to community resources, right? And we have a real responsibility to kind of know those resources in a deeper way, right? And so, it's not good enough that, hey, we went to, a couple of meetings when we were in undergraduate or graduate school, because it doesn't represent, if you've been to 2 meetings, you've been to 2 meetings. That's how many meetings you've been to.
Right.
And so, and we can also do that as professional peers, right? Where we're like, oh, I've been to 1,500 meetings, but they were all one particular pathway, and most of them were these 3 meetings, right? And so we all have some work to do in terms of understanding what is out there, both in terms of mutual aid, but also in terms of other services in our community.
Definitely, and that kind of harks back to our last panel where we're talking about making sure that we have the cultural context, working with folks in a way that supports them rather than alienates them. All right, so this is a list of all of the disparities between queer and non-queer folks in our study. These are all significant. I didn't include the ones that were not significant. So basically, on all of these metrics, queer folks are doing worse, statistically worse. The one part that they are doing better on is that they have lower symptom severity for substance use disorders. Everything else, though, not great. We also looked at identity support, and this is another new one. But this is how well the person's identity is supported within their CRP. So you can see in yellow, that's the queer identities, and in green is the BIPOC identities. Most of them are reporting that they are very well supported, but however, you want to see that there's about 25 to 30%, or actually 35%, who are reporting that they are not as well supported, and particularly looking at the not well supported for our BIPOC students. About 11% report that their identity is not supported within their CRP. So we looked a little deeper on this, and one of the things that we actually look at is a scale that is relatively new. So we asked 3 questions here: that staff are effective role models in my community, that they provide an environment in which I feel safe and welcomed, and that they care about me and my well-being. And when we ran the numbers, there was no difference between queer and non-queer folks, but there was between BIPOC and white folks. And that is mostly driven by the not feeling as safe and welcomed within the CRP community. I do want to point out that the scores are still relatively high, but there is a disparity, and that speaks to perhaps needing to look at our culture and how our services are best serving our students. So despite all of this, they are doing well. So when you look at that full sample on the left-hand side of the screen versus our 2 categories that we've been looking at, they're relatively the same. You know, high GPA, high reported quality of life, high recovery capital. So even despite all of the challenges, our folks are doing very well.
So we wanted to look at current functioning, and we wanted to start with some really interesting data. This is a paper that Noel Vest and several of us worked on, really looking specifically about justice-involved students that were in collegiate recovery programs. So we separated this group into folks who had been incarcerated and folks that were legal system involved. So they had formal charges, they may have convictions, but they have not been incarcerated. And what's really interesting about this is that our students that are formally incarcerated actually have higher recovery capital. They're actually doing better on a number of relevant metrics, okay? So they have higher GPAs, they have higher recovery capital. Most of that is, if we look at the model, most of that is explained because students that are formally incarcerated are older, and the older students in our sample are doing better on these metrics. So when you control for age, the big difference is actually that formerly incarcerated students are working a whole lot more hours. That's the one that it differentiates between older students that are formerly incarcerated and older students that are not formerly incarcerated. So this speaks to the systemic barriers that folks are facing in terms of continued lower earning capacity because of barriers in our society. So they're working a lot more. They're having to push that much harder because of the systemic barriers that they're facing. But I think the other side of this is any perception that these students are a risk to the institution is bullshit. That these students are a tremendous asset to the institution, right? And they're not just doing better than the other students in collegiate recovery programs, they're doing substantially better than other students at the university, right? And so we really need to kind of get rid of that narrative, and we still have barriers to just initiating higher education for folks that have past justice involvement. So as we look at this idea of recovery capital, This is something that a lot of us are doing more and more work around, or collecting more surveys around, especially as peer recovery specialists. And this really speaks to the kind of the sum total of your resources. It's largely focused on kind of positive things. And as people have higher recovery capital, they have more stable recovery, they have better quality of life, and better substance use outcomes. And one of the things we see in our student sample is that folks have very high scores on these standard instruments of recovery capital. So we use two different instruments, the BARC, the Brief Assessment of Recovery Capital, which is probably the one that most peers are familiar with, and then the SHORE, which is similar but has some nuance that we like. And we're hoping to kind of learn more about how these two measures are different. One of the things you see here, though, so this is, on the left, time point 0 is when they first take the survey, and just over time, people's recovery capital is very stable. So this is, in part, an indicator that the average student in collegiate recovery programs has a substantial amount of time in recovery, right? So their baseline recovery capital is pretty high, and whatever they're doing, they're sustaining that, but they're not going up. I guess in some world we would wish that that would go up a little bit more, but I think part of what we're seeing is a ceiling effect, right? And to me, this probably speaks to ways in which our research is still really focused on very, very early recovery rather than longer term kind of growth trajectories over time. The things that might be really, really important in early recovery that are measured relatively well on the BARC might be less important as somebody kind of meets some more developmental milestones as they get older, as they're more stable in their recovery. And so we're concerned there's a little bit of a ceiling effect here. You can't go above 60 on this measure, and because our students on average are already doing pretty well, that's kind of, there's limitations to this measure. So one of the other measures that's really important for us as people that work at a university is about retention, and especially in student affairs, we are really pushed around retention and the feeling of belonging. When students feel like they belong, they stay at the university, which means they pay their student fees, which means that I still have a job. And so when we are trying to kind of make the case to administrators, we have to say, we have to kind of make this case around belonging. And so the NCHA is the National College Health Assessment. That's kind of the most standard way that we measure kind of feelings of belonging at universities. And the participants in our study have substantially higher metrics on belonging, feelings of belonging, and feeling as valued as an individual. This is despite the fact that just experientially, folks are saying to us, I thought I was the only person on this campus. Right, so we hear that all the time, or like I didn't even know that this existed, or there was as much support as there is, and so this is really a shift as a result of being involved in this community. And so one or more communities where I belong is a really important metric of like, are people going to stay here and have a good experience in university or in college? In many of those cases, that one community is their collegiate recovery community. The other piece that we do look at kind of traditional substance use outcomes, and while a significant majority of our students identify as abstinent, not just from the substances they deem problematic, but generally from substances other than caffeine and nicotine, and they are maintaining their recovery at very high rates. We have a small subset, about 5% at any given time point, of students that don't identify as pursuing abstinence. And we'll get into specific definitions of abstinence. But what we mean here is taking prescribed medications as prescribed and not using drugs or alcohol other than caffeine and nicotine. So that's the definition we use in this study. And semester to semester, 85% of students are sustaining that abstinence point to point. So I want to kind of make some connections here that I think are really helpful outside of the collegiate recovery space, which is about kind of understanding the role of identity and and specifically kind of recovery identity or identities based around substance use in terms of people's experience. So what we know for a lot of people, especially younger people that have early onset severe substance use disorder, that they often have really strong identity associated with use, right? And so we have some qualitative questions about identity lost based on ceasing substance use, right? That people have this, that becomes part of who they are. They often experience the beginning of their addiction as like having friends finally, having something that worked, that sort of thing, right? And so that's going to have to be, if somebody's going to get well, they have to kind of grieve that loss of experience. On the other side, right, we want to replace that with something better, right? If we just take it away, and Dr. McCauley talked about this earlier, and there isn't a gain of membership into a new community, then we're not filling that void with anything, right? And so I think that's really helpful to think about work as peers or work as clinicians around this. And some people, largely experience their recovery in this kind of first way that's described, in that, their personality didn't change that much. They were just able to be more themselves, right? Or they're better to deal with things more healthy. Other people say, I experienced this huge change in everything, right? And then, and all the experiences in between. And those differing experiences are very normal. So some of the questions we're starting to get at in later iterations of the study is really trying to get at recovery identity. So asking questions like, what does recovery identity do for you? Does it allow you to be more secure? Does it allow you to face the future with optimism? And overall, people have very high measures on this kind of recovery identification, this identity focused on their recovery. That coexists, however, with really high rates of self-stigma. So it's this really interesting thing where both things can be true, where we have really high identity associated with recovery, but we still kind of blame ourselves for our addiction, right? And we still really feel the effects of that societally and in our day-to-day life, and that it is not fully a replacement, right, of that identity. There's still kind of some part of our identity that may be tied up in use or identity around use. So this is a really kind of interesting thing to look at. And when I think about the work that we do in recovery community organizations and in collegiate recovery programs, I often really think about this kind of place to develop this identity as a person in recovery as this tremendous asset that you have to bring back to your community. So I'm going to do one kind of complicated slide. What I put this together to really work with our coaches to be intentional about what strategies we are using when we're working with people, right? And so this is a little peek into my brain. Generally, in collegiate recovery programs, we're working with folks with severe substance use disorders, many of whom are now in full remission, right? But we're also working with folks that are newer, right? And that most of our folks don't have access to the quality of care that they would need in the community. And so we're really piecing together care through their peer relationships. And some of those students, their substance use goal is to reduce harm. That's the focus, right? And there is little desire to change use. There's desire to reduce consequences around use, right? So that starts at one end of the spectrum by just keeping people alive, right? But it might also progress to, as people are reducing their use, or kind of trying to get rid of consequences, it might say, well, I'm only going to drink after 5 o'clock on Friday night, right? And that is a very different conversation than a recovery-focused conversation, right? And so with our coaches, I say, in some cases, this piece of recovery priming, we're primarily working with somebody on harm reduction strategies. Recovery priming is your existence as a peer. As a person in recovery, you are introducing that person to the possibility of recovery. But if their goal is not recovery, then that's the only, recovery strategy that we're using, right? We're instead working on these harm reduction strategies. We might work on healing strategies, but it's not about kind of pushing towards a recovery identity, right? In some cases, right, we are pushing towards a recovery identity and giving people recovery strategies and trying to support them if they're trying to stop the use of one or more substances, or if their goal is a healthy relationship with substances. We're supporting in those things. We still may do some harm reduction, right? Like we used to call relapse prevention program planning, right? Is harm reduction, right? It's saying, okay, what am I going to do if the wheels come off the bus? That's kind of connected to this piece around that Mayor's going to talk about in terms of identity and how recovery identity can mitigate some of the harms. I do want to throw this in there that this is the future of the recovery field, right? That like almost half of our students are either currently work to or plan to work in the field. And so that's really powerful. I love to see this.
So most of you are probably familiar with the PCL-5, which is a trauma scale. We use the short form. We've only recently started doing this. Previously, we just asked, have you been exposed to trauma? And that's not terribly useful from a clinical standpoint. So on the PCL-5 for this particular population, because the scoring cutoffs are population-based, anything above a 7 indicates potential PTSD. And as you can see, our mean here is 7.91 for the group. Most of our folks are hitting clinical cutoffs for PTSD. You do not need to know this for the test. So basically what this is looking at is a regression, which is a type of statistical analysis that looks at the relationship between two different variables. In this case, we're looking at trauma and recovery capital scores, but we also threw in recovery identity. So in this case, I was going, you know what? We know that trauma makes recovery capital worse, and we're finding that recovery identity is correlated with higher recovery capital. But for folks who are above that clinical cutoff, the ones in the red, does it work the same way as it does for the folks who are in the blue? So we all want to have more recovery capital. Everybody wants to go see the ball game. Having more trauma makes it really hard to build recovery capital, and that's on that left-hand side where you have the low, medium, and high, and the kid who is in the high range can't see the ball game. So what we found was that for those folks in that high trauma category, having a stronger sense of recovery identity actually boosts them up higher even than the folks who have lower trauma and makes it easier for them to build recovery capital. Now, this is important because we can modify recovery identity. We can actually build up recovery identity by being strong role models, providing safe recovery spaces, and from helping them build up those social networks, that's what I research, of support from their peers in recovery, and all of that builds strong recovery identities, which in turn buffers people from having bad problems with trauma and having worse recovery outcomes. So kind of cool. This is very new research. We are still writing the paper, and hopefully will be out this year.
So I'm going to very briefly run through kind of our comparisons. So Spit for Science is a study here at VCU that's given to incoming freshmen. It's also a longitudinal study, and the focus is how to understand genetic influences and environmental factors impact substance use on college campuses. It started in 2011, actually worked on it when I first started working at VCU. And it's actually a pretty similar study design to ours. So what we did with this data, so there's a huge amount of students participating in this, is the teal color is Spit for Science. So this is kind of a pretty average college campus. I know that we have all this branding right now about being uncommon, but we're pretty like run-of-the-mill as a university on a lot of stats. You see kind of relative, still, these are pretty high rates of substance use disorder, right? Because 2 to 3 is mild, 4 to 5 is moderate, 6 or 7, 6 or more is severe. So this is still relatively high rates of substance use as we see on college campuses, but nothing like the participants, the past problem severity of participants in collegiate recovery programs, where more than 90% have experienced a severe substance use disorder. So same thing, illicit substance use disorder, very similar thing. We took the students at VCU that have high, similar rates of substance use disorder to the participants in the study, and we took out that subsample. And so we have these kind of 3 comparison groups. We have our national CRP study, we have our full sample of Spit for Science, and then the folks that have more severe issues. And our students in this measure have much higher GPAs, right, than either of the 2 comparison samples. Not surprisingly, the folks that have the substance use issues have the lowest GPA. And when we look at measures of anxiety and depression, what's interesting is that our core study students, our National Collegiate Recovery Study students, have higher rates of anxiety and depression than your average college student, but lower than the folks with the similar levels of past problem severity, right? So it's not that they are not experiencing problems, it's just that they are dealing with them better. They are kind of achieving better quality of life and GPAs despite the challenges. And so we can kind of see this with anxiety and depression. So still a huge number of our students are meeting clinical criteria on both of these things. Just in terms of anxiety for Spit for Science, right, it's way different. So just a huge difference in terms of anxiety of average college students versus folks in our study. So you see a little bit of this. There's still a lot of problems. Folks still need a lot of support well into recovery. So summary, higher GPAs, higher satisfaction with self, lower rates of anxiety and depression, far lower rates of substance use. Okay, so we want to leave you with just a couple of takeaways here. Mayor and I have been going back and forth on like how to explain this, and this is a beautiful ocean that I drew. And so if we think about like the depth as the extent of substance use here on college campuses, right? We do general prevention messaging, hey, water gets deeper. We do some more targeted prevention or harm reduction messaging. Hey, it's really deep, we're a life preserver, right? We might give out some life preservers, right? And then as we go to severe use, we're sending in the heavy artillery, right? And so part of what we're doing, right, is that these are services that are deep and not wide, right? And so what we really want to do is not just throw the life preserver, but we want to teach folks how to surf, because if you know my students, they're not trying to get out of the game entirely. They're really wanting to live really fully and kind of get back into the game. And so that's a little analogy. So here's our closing thoughts. So folks' identities matter, right? And so both in terms of BIPOC, LGBTQ, other identities, we heard a lot about neurodivergence, right? That matters to folks. It matters to have a space where people can talk about that. And the role of the helper matters, right? That the collegiate recovery professional, the professional peers that work in a space can help folks build identity around recovery, which can drive thriving and resilience, right? And by creating these systems of support, we are kind of creating the next generation of folks that are gonna lead us out of this seemingly endless epidemic, right? And then the last piece is that long-term support matters, right? And that we get to be engaged with students over years and decades, right? In terms of people continuing to have a space to re-engage as alumni and be a part of, and that creating those long-term support for folks really matters and really differentiates recovery work from treatment. The other thing is that this doesn't capture all of what recovery is. And this, again, is a very individualistic kind of study, right? It goes back to folks as individuals. And so it misses a lot of stuff that really matters that recovery community organizations are doing in our community and that collegiate recovery programs are doing for our campuses. And there's these impacts of reducing campus-wide stigma, having conferences, right? Creating the idea of recovery, right, on our campuses, and supporting recovery identities of folks that are not students. I can't tell you how many folks I've had come up to me and say, disclose that they're in recovery. Hey, I don't talk about this here. Or, hey, I lost my child to addiction, and I'm really glad this is here, right? So.
The other pieces that we're really looking at is how can we pull in that community of support, collateral healing? So how can we pull other students into the recovery movement? How can we not just reduce stigma, but create recovery allies? How can we pull in community members? Because we found that a lot of our students are actually using community resources to help their recovery. So how can we really make that a seamless, linked thing that they're moving through instead of these disjointed communities? And finally, family members. That's one of my areas of interest and also one of my students' areas of interest. How can we bring families back into the picture? Because for this age group, family is still very important. They are still transitioning to becoming their own independent family of their own. And how can we make that work better for them?
Cool. So thank you so much
Yes.
for sticking it out to the end, and hopefully we'll see you tonight for the party.